Go live now.
Good afternoon, doctors. Welcome to this webinar on Carbetocin in action from Hetero. Dr. Hetero Healthcare. We have got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio, presence in 126 plus countries, 21,000 employees globally, and we are amongst the largest manufacturer of ARVs, APIs in the world. We have got Asia's largest API manufacturing factory at Visakhapatnam, Andhra Pradesh. Hetero Healthcare provides 360-degree solution. We strive to fulfill unmet healthcare needs, reaching out to customers across India. We have a wide product range encompassing multiple specialties like orthopedics, pediatrics, gynecology, etc. We pioneer in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar on carbetocin is carbetocin and use of carbetocin in PPH. We all know PPH is a serious condition, potentially serious condition, and can lead to disasters. To give their insights on PPH management with carbetocin, we have expert Dr. Samir Pradhan today with us. Welcome, Dr. Pradhan. Dr. Samir Pradhan, just to mention a brief about Dr. Pradhan. Dr. Samir Pradhan is MD, DNP, FCPS, DGO, DFP. Sir is Director at Samarth Maternity and Nursing Home, Mulund. Is affiliated to Godrej Memorial Hospital, Vikruri, Fortis Hospital, Mulund, Jupiter Hospital, Thane West. Dr. Pradhan has special interest in vaginal surgeries, high risk obstetrics, advanced operative laparoscopy, and urogynecology. Sir has been recognized for best video on vaginal surgery. He is invited as moderator for live surgery demonstration and invited faculty for live operative procedures. Dr. Pradhan is Joint Secretary, SOVSI, Maharashtra chapter. Welcome, Dr. Pradhan. And now I'll hand over the session to you.
Thank you, Dr. Prashant sir, for this kind words of introduction. Can I share my screen?
Yes, sir. Yes, sir.
I don't know what happened. Okay. It's it. So it went to the last slide. 1 minute. I'm just. So is it full screen visible now? Hello?
Yes, sir. It is visible.
Yeah. So I just share my experiences with Carbetocin. I am aware that all of the present generation obstetricians and obstetricians must have shifted to Carbetocin because it is a smarter, superior, and safer choice in the PPH management. My first case, I want to discuss a case of cesarean section. She was a 32-year-old gravida 2 with one abortion, IVF conception. She was around 36 weeks gestation, type 2 diabetes mellitus, on injection detimir, that is a new insulin analog of rDNA origin. The dose was almost 26 units subcutaneous after dinner. She also developed throughout in the pregnancy after 28-week gestational hypertension without proteinuria, for which she was well controlled on Nicardia retard, 10 milligram TDS. I do routinely the alkaline phosphatase at around 32 weeks for all patients, and that time it was raised. So that is why I started her on tablet ursodeoxycholic acid, 300 milligram twice daily. At around 35 weeks, the patient complained of decreased fetal movements. We admitted her. The Doppler was done, which was normal. NST was reactive. We gave prophylactic betamethasone for the fetal lung maturity. 2 doses of 12 milligram 24 hours apart. Serial NSTs were done. The baseline variability was reduced in the third NST. So after the second dose of steroid, we ran her elective cesarean section because she had an IVF conception, first miscarriage, hypertension, diabetes, and there was also a nuchal loop of cord, which we diagnosed later on, not during earlier. So there was a nuchal loop of cord during the cesarean section, and the head was deflex. So we delivered the baby by a cage forceps during LSCS. After the delivery of the baby, we waited for 30 seconds and then clamped the cord. And after that, I told the anesthetist to give injection carbetocin. It's an oxytocin analog, 100 micrograms diluted in 100 ml normal saline and not 100 ml, 10 ml normal saline and IV over 1 minute. Cord blood was corrected, uterine angles were taken, placenta was allowed to separate on its own. We now have stopped doing MRP. We have noticed that once this carbetocin is given, the placenta separates quite fast and there is hardly any need of any other tocolysis. LSAS was, sorry, any use of any other uterotonics. LSAS was completed, no further uterotonics was required. There was no PPH. Post-operatively, for all cases after the cesarean section, we put 600 micrograms misoprostol in the rectum with the Justin or the diclofenac suppository. Second case was a normal delivery after a second trimester MTP. She was a 33-year-old patient with a very high BMI, gravida 2 para 1, living 1, admitted for second trimester MTP for failure of contraception. The diagnosis was delayed because she had irregular menses, and only when she started feeling something in the stomach, some bulge, that time she decided to go and seek the opinion of her family doctor. So it was already a 15 to 16 weeks gestation. We did the standard second trimester MTP protocol, mifepristone 200 milligram oral, followed by 36 hours later by misoprostol. Since she was previous LACS, we gave 400 micrograms misoprostol first, and then 200 micrograms was repeated every after 4 hours, 8 hours, 12 hours, and 16 hours after the first dose. After almost 20 hours after the first dose of 400 microgram misoprostol, the patient aborted. It was a 80-gram abortus and delivered as breech. Cord was clamped and injection carbetocin was given. In this case, I gave it 100 micrograms IM, ampoule was given IM with a 2 ml syringe. The placenta was not yet delivered. Patient was shifted to the OT. Anesthetist was called. We catheterized the bladder, which is the important step to prevent a post-abortal hemorrhage. And almost after 30 minutes after the delivery of the baby, the anesthetist had come and then given the anesthesia, short GA. We traced the cervix, and then placenta and membranes by that time had already separated and were lying in the lower uterine segment. We just delivered them. Check curettage was done as I do routinely with the AV retractor. And we always keep a LRV balloon or a panicker small length cannula ready, because sometimes I had seen in the pre-carbetocin days, after this check curettage, sometimes there is a lot of gush of bleeding. Post-procedure, the LSA scar was traced and no further uterotonics were required. Now, one high-risk case, it was a very rare case. It's one of the highest surgeries I have done in my nursing home in cesarean section. Primary gravida, 49 years old, high BMI, 99 kg weight with 165 centimeter height. The BMI was almost 39 kilogram per meter square. IVF conception, obviously donor eggs. Alpha thalassemia in the mother, it was twins. Type 2 diabetes on Mixtard 50-50, 26 units before breakfast and 20 units before dinner. Actrapid insulin 8 units, 18 units, and 6 units 3 times a day, on which her HGT used to be between 140 and 160 milligrams per deciliter. She also had hypertension, luckily without proteinuria, and was on labetalol 100 milligram BD, Nicardia 10 milligram BD, Udiliv 300 BD for the raised alkaline phosphatase like the first case. PTINR was normal. For all such cases, we do a uric acid, which was raised 7.9, and a fibrinogen. There was severe edema feed, including anterior wall edema with umbilical hernia. When she first came to me at around 26 or 28 weeks, referred by the IVF consultant, she already had severe edema. So I did a venous Doppler to rule out any DVT. Usually she was a diamniotic dichorionic twins. First was oblique cephalic deflex head. Second was a complete breech with extended arms. And then one of the twins had a placenta previa posterior, but type 1. And to add to all this complication, there was the blood group was A negative. Luckily, we could reserve 2 pints of blood. For the same patient at the IVF center, I had done a prophylactic Shirokar circlage at 17 weeks. and I decided to voluntarily cut the knot 12 hours before the preterm LSS was planned at 34 weeks. This was planned because of the maternal distress and the obstetrician stress. Because with all these high risk factors, I did not want her to land up with a sudden IUFD because diabetes also was type 2 and quite high dose of insulin were required. So elective LSAs was done. The twin A was a female 2 kg, twin B was male 1.9 kg. Carbetocin 100 micrograms slow IV after the birth of the second twin was given, diluted in 10 cc normal saline. But here, to be on the safer side, as the age was high and the uterus was over distended, I obviously could not give oxytocin drip because I had already given carbetocin. So I decided to give 250 micrograms of carbopros. She had no history of bronchial asthma, so I gave that intramyometrially. No methadone, no pitocin. All such high risk cases, we give a tranexamic acid 1 gram pre-op and post-op misoprostol 600 micrograms. There was no PPH. This was a photo at birth, and after 3 months, the babies were quite good. So this was one of the very high risk cases I have done. And with carbetocin, there was hardly any requirement of other uterotonics. Carboprost I gave because of my safety and RH negative. Otherwise, probably retrospectively thinking the uterus was contracted on, even with carbetocin. Just a brief overview of postpartum hemorrhage. We all know it is defined as a blood loss of at least 500 ml or more after the vaginal delivery or at least 1000 ml or more after the cesarean section. It can occur even in women who are not at risk. And it is a leading cause of maternal mortality in low resource countries. And it accounts to almost 1/4, 25% of all maternal deaths globally. So in the developing countries, the maternal mortality rate was 240 per 1 lakh live births compared to 16 only in developed countries. The main etiology, we all know the 4 T's. One is the tone, hyperdistended uterus, or other reasons the uterus can be atonic, which we call atonic PPH. Then next is the trauma, or there can be a birth trauma, either a cervical tear, vaginal lacerations, or there could be a hematoma or a rupture of uterus. Even uterine inversions, sometimes if the placenta is full, can cause atonic PPH. Tissue, if the products of conception or the placenta and the membranes are not removed completely and some tissue remains, it can cause PPH. And the most dangerous is thrombin, that means DIC. The patient has coagulopathies, there's failure of clotting, then they can have PPH. So degree of shock depends on the amount of blood loss. So if there is a up to 1000 ml, that is a 10 to 15% blood loss, then usually there is no change in blood pressure. Patient may have some giddiness, pulse may be slightly high, and there can be palpitations because of the tachycardia. If the blood loss reaches up to 1500 ml, that is almost 25%, then the BP can drop to below 100 or below 80 millimeter systolic. Patient will start getting weakness, sweating, tachycardia. Any blood loss between 25 to 35%, that is around 2 liters, there could be a marked fall in blood pressure. One should not wait for this stage to occur. If one puts a Foley's catheter, one will find hardly any urine output in such cases. And severe means patient is in shock. That is almost 3 liters of blood is lost, more than almost 45%. The patient is in shock. The BP goes below almost up to 50, 60 systolic. Patient will have a gasping type of breathing. So what one has to do is, first thing is, in any case of PPH clinical findings, if you have attempted an instrumental delivery, you just check for any traumatic PPH. As a protocol, after all deliveries, the placenta, you should not pull on the placenta, allow it to separate, then remove it by the Brandt Andrews method. Keep on twisting the placenta so that the membranes are coming out completely. And one can do always a blunt curettage so that no tissue remains inside. Any high risk cases, do a fibrinogen. And then keep on monitoring the tone. The bladder should always be empty and check for vaginal bleeding. There is always a fourth stage of labor, which is mentioned in Oxon food, that is 2 hours post delivery. In our institution, we used to keep the patient in the recovery room or the RR. And uh, Here we used to see, and only when the patient passes urine after a normal delivery or the after cesarean section, the pulse BP, urine output is adequate, and the uterus is well contracted and a cricket ball uterus, only then we shift the patient to ward. So how does one diagnose? The rapid assessment, as I just mentioned, trace for the lacerations, examine the tissue. If we have a bedside ultrasound, which is there in few of the labor rooms, one should evaluate if anything is retained inside. And if you pull very fast after the baby, try to remove the placenta, then the uterine inversion can cause a neurogenic shock element also. If any patient is having excessive bleeding, one has to send the complete blood count immediately. Platelet count has to be known. We do a PT and a APTT and always a serum fibrinogen. It should be always above 200 milligrams per cent. So these are the various causes. I am not going to go through all this. I think everybody knows how to manage a postpartum hemorrhage. The uterotonics, which we know, the oxytocin was a traditional uterotonic. Prostaglandins have revolutionized the bleeding, means the PPH management. And earlier we used to use prostodin, but we cannot use prostodin in bronchial asthma cases. Then misoprost has come, which is quite safe, but very high dose of misoprostol can cause fever. Methargine and other alkaloids were very good, but of late, their IV methargine have caused certain cases of peripartum cardiomyopathy. And it causes severe nausea, vomiting. Even prostodin can cause vomiting and diarrhea. So this carbetocin is an analog which is quite safe. This is what we already mentioned. Why carbetocin is important is now it is heat stable formulation. When it was launched, it was had to cold chain needed to be maintained. But now it is available in room temperature, stable formulation, and a convenient vial preparation. It has a shelf life of 24 months at 30 degrees and a 75% humidity. Avoids need for cold chain and other logistics, and is provided in a vial. Now oxytocin, prostodin, we have to keep in fridge always. Heat stable formulation of oxytocin is currently not available. And the previous formulations of carbetocin were required to be stored at 2 to 8 degrees centigrade. So if one does not have a proper cold chain for those, then the drug will not act. So now with this new molecules which are stable at room temperature, that need of refrigeration is not there. When do you admit carbetocin? So obviously one way is at the delivery of the crowning of the head. One cannot give methargine at the crowning of the head or the delivery of anterior shoulder because it causes closure of the cervix and the placenta will remain retained. However, one can give carbetocin at these stages. But we prefer to give at the end of the second stage of labor after the baby is born, before the delivery of placenta. Very rarely, if everybody is busy, one can also give it after the delivery of placenta. It will take cause slightly more bleeding, but it will still okay. Prophylactic use, as I had mentioned, prevention of PPH and active management of third stage should be practiced. In a private practice, if we have an assistant, it is good. But if we are short of hands, we make a point to call an anesthetist because anytime we require additional help, it is better. If the pediatrician also does not reach on time, then the anesthetist can help with the baby's resuscitation. So one extra hand in a nursing home is always better, and that one should fill the carbetocin in a 10 cc normal saline, diluted and label it and keep. So as soon as the placenta is separated, one can give it, or even it can be given after the baby is born. So it will aid in the placental separation. So what is carbetocin? You can see the structure is more or less similar to the oxytocin structure, but it is a synthetic long-acting analog. Oxytocin half-life is very less, but carbetocin half-life is almost 40 minutes. So what it does, it prolongs the half-life and reduces the enzymatic degeneration. So it can be used for the prevention of postpartum hemorrhage due to uterine atony. So far, carbetocin is not still sanctioned for the treatment of atonic PPH. Meaning, if prophylactically you have given carbetocin and then the patient is still bleeding, then one should not repeat the dose of carbetocin. Then after 40 minutes, you can give oxytocin drip. Oxytocin will not act for the next 40 minutes because carbetocin will be occupying all the receptors. So then one has to go to alternate eutotonics like methergine if the patient is not having a heart disease or PIH, or if no asthma, then carboprost or misoprostol in different routes like sublingual or in intra in the uterine cavity or per rectally. Now, what is the clinical evidence? The efficacy and safety of carbetocin and oxytocin was compared, and it was the WHO champion trial which showed that carbetocin is non-inferior to oxytocin. So what does this non-inferior studies mean? Means the previous drug also is equally effective, uh, but this drug also gives the same effect. And then then one has to see the convenience of use because oxytocin will going to require a cold chain. 4 ampoules have to be broken, given in a drip form. Giving IV oxytocin in the bolus is a bit dangerous. So this is what the non-inferior means. And it reduces the need of any other eutotonic agents as compared to oxytocin because we have been using oxytocin all these years, and sometimes we have to give methergine with it. We have to give prostodine, carboprost, or misoprostol. Then there was a comparison with single dose oxytocin with carbetocin versus continuous infusion of oxytocin. And here also carbetocin single dose was found to be non-inferior. So in a heart disease patient where one has to restrict IV fluids, single dose carbetocin will be definitely scoring over oxytocin. The blood loss was compared and both were almost similar. And then there were studies which compared carbetocin with syntropatrin, that is methergine, and with misoprostol plus oxytocin. So in all these studies, it was found that it is non-inferior. So this is a champion trial conducted by WHO, Development of Reproductive Health and Research. It is a double-blind randomized trial, so it has a very scores very high on the this study design, and it compared the heat stable carbetocin to oxytocin in the prevention of PPH after vaginal birth, and almost 30,000 women, so a very huge cohort was taken across 10 countries, including India. The proportion of women with blood loss of less than 500 ml or the use of additional oxytocins were the primary outcomes. And in cesarean section, the proportion of blood loss less than 1000 ml was the endpoint. And if you see the comparison, it's almost same, like 14.5% women in the carbetocin group had blood loss more than 500 ml after normal delivery, on 14.4 in the oxytocin group. And in a cesarean section, it was 1.5 in the carbetocin group versus 1.45. So it was concluded that the carbetocin was non-inferior to oxytocin. Then there's a Cochrane review of carbetocin for prevention of postpartum hemorrhage, of which 11 studies involving 2, 6, 3, 5 women were studied. And for women who undergo cesarean section, carbetocin resulted in statistically significant reduction in the need of therapeutic eutotonics compared to oxytocin. And also associated with less blood loss compared to syntropatrin, that is methergine, in the prevention of PPH for women who had vaginal deliveries, and it has definitely much less side effects than methergine. So the guideline recommendations are WHO 2018 guideline for prophylaxis of PPH, not for therapeutic use, is any one of the following. Either you can use an oxytocin drip or oxytocin IV through an infusion pump, or carbetocin as an IV bolus over 1 minute, or misoprostol or methyl ergometrin, or there were combinations of oxytocin and ergometrin. Canada says 100 micrograms IV bolus of carbetocin. New Zealand, the Ranscock trial had used carbetocin for active management of third stage. FIGO has mentioned carbetocin as one of the recommendations. Germany and Australia and the Switzerland, that is the European countries, are saying it to be given 100 micrograms slow IV. And France also is going by the champion trial. So I think now we will have the questions. I will stop my screen sharing, and I think sir will take
So
from.
we can continue with this.
Okay, we
We'll
can.
go. Yes.
So
I
yeah,
mean, you have
so
already said you have talked about your experience with carbetocin. One
yeah,
interesting case I saw that it was used in one patient of with RH negative.
yeah.
Yeah, this is the first time I saw actually the case was RH negative. And what is overall experience using carbetocin?
So basically, the thing means if I use my protocol, basically carbetocin after the baby is delivered,
Yes,
and then I wait for the placenta to separate. When we earlier used to try and take the placenta out during a cesarean section,
manual, manual.
but that manually, but that can cause more
Yeah,
bleeding. So now we
absolutely,
wait for it to separate. Only if it is there is any history and it's manually adhered, or then those cases we have to manage differently. The
absolutely.
meantime, when the placenta is getting separated, we just take the angles. I now don't deliver the uterus outside. I had learned it that way, but then in 2010 I changed because I had also that time was learning from Dr. Deepak Desai about how to do a extraperitoneal cesarean section. So the first criteria for that was to try and keep the uterus inside. Extraperitoneal cesarean section, I was not much convinced, but this other technique of not delivering the uterus outside cost less PPH than otherwise. And then with carbetocin, we hardly require anything else. That is what we have seen in a
Correct.
low risk setup. In a high risk, in a nursing home setup or wherever we don't want to wait to uh, uh, let the patient bleed. So some cases like which I showed you, RH negative and all,
Yes,
I
yes, yes, yes.
preventively immediately after the babies were born, carbetocin was given that carbopros in such cases is ready on the trolley itself in the start after the bronchial
Absolutely,
aspiration.
absolutely. Yeah, yeah.
And then we err on the side of having no bleeding because we don't want
Correct.
to try and error, have try and error in those cases.
The next one question. Is there a specific patient profile where doctors can anticipate a PPH?
Yeah, of course. For atonic PPH, we all know over distended uterus. So if there is a
Uterus,
polyhydram
twin
news
pregnancy.
or there is a twin pregnancy, then we are the uterus is going to be over distended. So we are going to expect PPH. If there is a leaking per vaginum, it's called PROM, premature
Oh,
rupture of membrane,
rupture of membrane.
and some sort of chorioamnitis is already set in, then such patients are going to have PPH. Then
With fibroid,
is
patient with
having
fibroid,
patient all fibroids don't have PPH, but if the
okay,
fibroid is intramural, then sometimes it affects with
intramural.
contractility. Then basically, if there is a patient is having antepartum hemorrhage in the first trimester or some other time, or there is all this low-lying placenta or abruption, then they are prone to have postpartum hemorrhage. So those are the conditions. PIH cases have a hypertension, or even chronic hypertension in pregnancy. So the blood pressure is high, then there's a more chance of bleeding. If you pull on the placenta and then cause some partial inversion also, then the uterus takes more
Yeah.
time to
Yes, yes.
contract. And a prolonged labor means if your patient is in labor for a
Uh,
long time, one has applied vacuum forceps, failed, and then gone to this, then there is
Possibly a fatigue, uterine fatigue. Yeah,
uterine fatigue. Like sometimes there's maternal exhaustion, maternal distress.
yeah,
We in
yeah,
our
yeah.
normal practice we don't do the ABG in obstetric practice, but such patients may be having some element of acidosis and the breathing is a bit heavy, then those patients can have a postpartum hemorrhage. And then if there is
Patient with patient with diabetes can be predisposed to, I mean, they
diabetes
can have
per
PPH.
se is not known to cause PPH directly, but
Okay,
the
okay,
patient is obese diabetes, then that obesity
okay,
can cause some PPH. A
okay.
well-controlled diabetes normally, diabetes having a vascular element, then also there is an element of PPH.
Okay. When would you actually prefer carbetocin over oxytocin? Oxytocin is our textbook brand, which we have been studying. But
Basically,
actually,
suppose I have use oxytocin to augment the labor. Like suppose a
uh,
patient has come in labor
yeah,
and I have
second
to hasten
stage.
the process and normal
Yeah.
delivery. Like suppose I done an ARM and patient I want to give her, I want to deliver her fast and I give her pitocin. Then I will not give carbetocin. I will just add another. The drip is already going on, and 5 units pitocin is going on. So I'll add another 3 ampoules, 20 units to the drip
Okay. Okay.
after the baby is born. But if there's an
Okay.
elective cesarean section or now suppose that is a cesarean section I have done, like a patient I tried for normal delivery and just failed, then I had to do a cesarean section. Then I stopped the pitocin drip and
Okay.
then after the cesarean section, that time I still have not used carbetocin because after delivery I
Oh,
am not sure like what they say carbetocin after carbetocin you cannot use pitocin for next 40 minutes. Whether the
okay.
reverse is true, I'm not very sure. So I want to ask whether if we use oxytocin, how after oxytocin we
Yeah,
drip?
sometimes the receptors being same, sometimes you may not get action.
Yeah, receptors will be occupied, but
Yeah,
oxytocin
yeah,
is
yeah.
shorter half-life. So how much time the receptors will be occupied?
There's
That
no
I have not
documentation
tried.
about time. Hmm.
So I have tried it
This,
only for elective cesarean sections. So
okay.
in normal deliveries where a patient has come and delivered, which is very rare nowadays because we do some augmentation.
Correct.
So my main and in those second trimester abortions I have tried because there we don't have
Okay.
oxytocin.
What the fourth one?
Yeah.
Can you use carbetocin in case of
There
retained
is been a
placenta?
studies where long when I did my residency almost 30 years back, when the placenta was not coming, we used to dilute pitocin and give it through the cord. So there have
Yeah.
been studies where the carbetocin also was given in the cord and the placenta separate.
Acha. Separated.
I personally have no experience of this.
Yes. Okay.
Because I will
Next.
because it is something like it may act, it may not act. I have not seen.
Absolutely, absolutely, absolutely. So
Pitocin is the
people,
cheaper version because I take 10 units pitocin. The ampoules are cheaper than the carbetocin ampoule. So what is something trial and error? I normally prefer oxytocin. If something is
right.
poor, I prefer carbetocin.
Fully understand. You already used this
I
question
use
is
it. I
not
don't think there should be
yes.
see what one should understand is in Rh negative even methergine that said as a contraindication. Why the contraindication was there? Because there is something called a Clear-Betke test which assesses the fetal-maternal bleed during the
Hmm.
delivery, which we nobody does basically. So if the baby is Rh positive, we don't know the baby's blood group. The fetal-maternal bleed occurs during labor is the maximum, and we give a standard dose of 300 micrograms of anti-D. So if the bleed is very severe, then this 300 micrograms will not be enough. That is why they had told not to give methergine because methergine, what it does, it causes severe contraction of the uterus.
Contraction.
A lot of baby's blood would have gone in the maternal circulation, and the fetal-maternal bleed load would have been more. But I don't think carbetocin has caused such a massive contraction because we are given it as a prophylactic. Like when
Correct.
we give this, we don't give methergine even after the anterior shoulder is born because, or even in a twins after the first baby is born.
Suddenly contraction.
Yeah,
Yes.
because
That is called.
cervix closes and everything will remain inside.
Hmm.
The placenta will be
So,
retained.
yeah. Yeah. And in the patient whom you use, I mean Rh negative patient whom you use, the recovery was uneventful, completely normal,
I mean, is there
smooth.
anything that is not to be used? Rh negative.
No, 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 no. It is a question which has, I mean, this is the first time I've seen using the RH negative, and I'm very happy because this
I
question has come
think I
across
used it
India.
Rh negative. Means I don't.
Yes, good,
I was
good.
not. I did not come across any contraindication of Rh negative.
Exactly,
The
exactly.
Rh negative contraindication
I,
which I said was basically of the fetal-maternal bleed, and then even if you give a anti-D, the patient may be immunized in the next pregnancy. That is the only concern I
the
feel.
PPH, if a RH negative lady, if she gets a PPH, there's trouble getting blood, etc., etc. It's better to use.
No, but we are, yeah, better to use prophylactically. It's I think
Yes,
carbamazepine
no,
is only for prophylactic use.
you're
For
correct.
therapeutic use, so we have to wait for 40 minutes after the last dose of carbetocin. Otherwise, the oxytocin will just cause volume overload. But we have
Absolutely.
other medicines and we have other. Suppose it's the atonic PPH and you are given
Mm.
carbetocin and it has not acted. then you should start the methergine. One can give, they say up to almost 8 doses of prostolin can be given, but I have not given 3 to 4 doses. Up to 2 or 3 doses I give prostolin. I use
Correct.
put misoprost 600 or 800 milligram in the rectum, massaging methergine 1 or 2 ampoules, because then the patient also get vomiting, diarrhea, and everything. So that also.
Side effects, side effect.
And
Yes.
I told you in my second slide, this I had kept. I have LRV. We are all Manyata registered by Foxy. So we have a tray. All my staff nurse knows. So if there is a
Okay.
PPH tray, if we ask, like we have a eclampsia tray and
Uh,
a PPH tray. So that tray has
correct.
a balloon. I have this Panikar cannula or Samarthanam
Okay.
cannula. So one has to act very fast, and you should have a if the bleeding is the patient the uterus is like a gunny bag and it's just pouring blood. One has to
Oh,
do definitive surgery fast. Means if
absolutely.
in a cesarean section, one should do a uterine artery ligation or a B-linch, or if there's a and if there is a already a known placenta previa or whatever, one has to anticipate that. Do it in a, if your nursing home is equipped, good. Otherwise, do it in a tertiary care institute where blood is available. Keep everything ready.
Correct.
So
Correct. Correct.
anticipation and
Correct.
doing it fast is important.
Absolutely. You go to the next one.
I cannot. I will not use carbetocin for prevention of PPH if oxytocin is already used for labor induction.
Yes, you
But
said that. Yes.
I don't know how much time the
The receptor will be occupied.
doc, so I don't want to take that chance only.
Correct. Correct.
I mean, I cannot try it. It is I will act, not act, and then there's bleeding because
You can't.
if
Yes.
the patient loses blood, then sometimes goes into irreversible stage, and then
Correct.
I will prefer giving a better. Other drugs also available, no? So why to
Yeah.
limit
Yeah.
use the uterus? So, so I have not used.
It's a big risk. It's a big risk.
Yeah, yeah.
Correct. Next question, sir. Any specific place where you use IV or
So
prefer
if
IV or
anesthetic
IM,
is
or you
available,
always
I
prefer
ask her to
IM?
give IV. If anesthetic is
IV.
available
Otherwise,
and from staff and I'm bringing the baby, I tell them to give IM.
IM.
Huh.
The next one.
But I don't know, the staff will give us a very fast bolus, 1 minute. I
Absolutely.
told him, but then in a nursing home setup, almost anesthetic will not be available for a normal delivery.
Correct.
Then I
Correct.
prefer IM route and I give the IM after the baby is born. So it will take its action, let the placenta come on its own time. If there is
Perfect.
any bleeder in the meantime, I'll put a artery hemostat in the bleeder and keep everything ready. Keep one staff with the baby with the mother. I will go and manage the baby till the pediatrician comes. By the time I come, the placenta is out. Then I do a manual
Yeah.
that side. We empty the bladder always. Then we see that the uterus becomes tonically contracted that time only.
Correct. Correct.
Then
Correct. Correct.
then that's the IM is quite good enough. Yeah. And then we put a misoprostol tablet also that time. So that also will act.
Interactally, yes.
Yeah, for
Next
rectally.
one.
And then we change the gloves and then do the suturing.
If the patient is
For
not responding,
responding, obviously, first choice will be misoprost 600 or 800 directly per rectally or sublingually
carboprost,
and
yes.
carboprost.
Carboprost, yes.
And sometimes if the placental bed is bleeding, then
Uh,
methergine has a, besides the uterotonic action, methergine has a
vasoconstrictor,
vasoosmotic action,
constrictor,
for
yes.
vasoconstriction. So all the small vessels it constricts, so it has helped. I still use methergine, and my mother
Yes, yes, yes.
anesthetist, and she was a very big fan of methergine. Now the
Okay.
anesthetists are not very fond of methergine, but methergine we always give IM. We very rarely give IV. Mhm. Because
So during my time in college days, we had only oxytocin and methergine, nothing else.
methergine, I still it's a not a means it has gone like a few cases of peripartum cardiomyopathy were reported. That's why
Correct,
anesthetic
correct,
now
correct.
not
Yeah.
very.
Now, when you have got better alternatives, now we'll prefer.
Yeah, yeah, yeah.
So the
And
next one, please.
what are the advantages of
You,
carboxyl or
yeah,
oxytocin?
you have already said,
Dose
yes.
is same, a single dose, and we don't have to give IV fluid.
Correct.
Misoprostol, like it sometimes can cause fever, which carbetocin does not cause. Carboprost cannot be given in bronchial asthmatics, and it causes
Asthma.
vomiting and diarrhea, which is not seen with carbetocin. Methyl ergometrin has a lot of contraindications, never to be given in heart
Correct.
disease and hypertension of any kind. because of the vasoconstriction, it causes dual
Yes, yes, yes.
that is the thing. And also Rh negative, we don't give methyl ergometrin for that fetal bleed part. It's mentioned. And I
So
think
have you seen any fluid retention with oxytocin?
fluid retention,
Fluid
we have not
with
seen it
oxytocin?
is mentioned because
Mentioned, yeah, documented.
modern obstetrics, we don't wait for 2 or 3 drips. Like earlier,
Okay.
when we did not have prostaglandins, there was something called a priming drip of oxytocin for a
Hmm.
poor Bishop score, where oxytocin was given for 1 or 2 days and to
Correct.
prime. So then that is because of the antidiuretic hormone effect
ADH,
of
correct, correct.
oxytocin
ADH effect.
that is known. So recently, what they told in one of the critical care workshops recently attended was not to use 5% dextrose at all. There should not be any 5% dextrose in your labor room at all. Even DNS they said to avoid and give the oxytocin
Okay.
with RL.
Acha,
I
renal
used to give it
lactate
with
state.
DNS till now, but they said to give it with RL because of that ADH
Okay.
effect. And
Hmm.
even in our like in a private, we hardly manage heart disease with pregnancy, and nowadays we don't see
Correct.
so much heart disease because rheumatic fever itself is controlled.
Yes,
Uh,
yes, yes.
but when we were in residency, I was with Dr. Vinita Salvi. We used to get all the heart disease from everywhere.
Yes,
We
yes.
used to use concentrated oxytocin that time. Like instead of 5 units,
Acha.
we used to use 7.5 units. So
Right.
we used to give a lower drip rate. So we have that is mentioned in the books also. And in private, suppose you have a syringe pump, it is an easier way
Hmm.
to titrate oxytocin and give. So you can give concentrated oxytocin in whatever dose is required. So that way you can
Right.
adjust. So I don't think oxytocin fluid overload will be more of
It's
a iatrogenic complication. It should be avoided.
go to the next question, sir. Should carbetocin be kept as a reserve drug or as a first line?
I think it should be first line and reserved
First line, yeah.
should be other line. Because if you have given something else and it has not acted, I will not err on the side of giving carbetocin as a
Absolutely, absolutely. Yeah.
because uh, then I don't know. I'm not sure. I had to act differently, and probably if medicines are not working, I had to act surgically fast.
Surgery, yeah, surgery. Life is at stake finally.
Yes, yes, yeah. So
Yes.
that means I will not. If I have to use it as a first drug, it you acts well and good. It does not act,
Correct.
I go to the other things.
Right, right. You can't risk.
Yeah.
I mean, we already discussed this adverse effects, side effects, contraindication of carbetocin over. It's the last year take one line on carbetocin.
So basically, it is a new drug. So and it is expensive, which I also was having a reluctance to use initially. That was my question, and the study showed it is a non-inferior use, but it is very
Correct.
convenient, especially for elective cesarean sections or if it's a normal delivery where you did not have to use much of oxytocin to augment. And it should always be and the heat labile variants are much better because you don't have to worry about the cold chain, and it is very safe. It can be used in Rh negative. I have used it can be used after delivery of the baby, and it can be used for retained placenta, and it is quite well tolerated. I have yet to see any side effect with carbetocin.
Excellent. Thank you so much, sir. Thank you for your wonderful insights on PPH and carbetocin. It was lovely.
Yeah.
Thank you. I'm sure the audience must have benefited. Thank you all the doctors who attended this webinar, taking time from your busy schedule and attending this. Thank you, marketing team Hitro, Priyanka and your team for conceptualizing this. Thanks, field people of Hitro for coordination. And thank you, IT team Jayant and your team for backup support. Thanks, all of you. Thank you, sir, once again.
Thank
I'm
you so much
signing
for the
off.
opportunity. Thank you very much. It was my
Thank you, thank you, thank you. Signing off. Thank you. मस्त झालं सर.
चांगलं झालं. प्रॅक्टिकल आहे ते महत्वाचं असतं ना.
हो, सर तुमच्या इन्साइट्स फायनली उपयोगी असतात ना. म्हणजे टेक्स्टबुकमध्ये काही